Acupuncture, particularly for pain management and pain control, is what we would see that other than healing factors of acupuncture, it's more for pain control. For me, manipulation is a strong thing to be used in the polio population because of their abnormalities in their gait and their biomechanics, that often there's restrictions of motion in other areas that if I can resolve by doing manipulative treatment, then they'll be better able to ambulate in a more effective manner, might tolerate their bracing better, have a decrease in pain, increase in their breathing ability if they had any kind of breathing problems with regards to their polio, improving respiratory drive. All of those things have been proven effective with manual medicine or manipulation. Can't tell you that there's specific studies that are involved for the polio population with regards to that, but
maybe there's another research.
Yeah. So there's, like I said, there's a lot, because there hasn't been a lot of research done in the polio population. Yeah, there's lots of avenues to go, but having more people involved in trying to set up those protocols would be, I think they're difficult. Manipulation in general is a tough thing by a research study to prove. Then if you throw post-polio population involved with that, it's going to make it into a very difficult project. I more check for how my patients are doing, and clinically, do they feel like it's beneficial, and the overall consensus has been yes, they feel like that's an adjunct to their care. It's not their only thing that they do, but it is. Well, myself, I do osteopathic manipulation, so I'll use that. We have a massage therapist here as well as acupuncture within our group. So I believe that having those alternative treatments are necessary and effective. I use them myself. Within a 3-day meeting, it's hard to take on all of that as well, but absolutely I would have the patients look into that and introduce any of those treatments that they feel were beneficial. That I think that they should try everything they can to find other modalities that might be helpful, because medications with the side effects and the other fatigue factors that we have, we would like to avoid as much as possible. There's a big dispute with regards to EMGs and post-polio, and should they be done. My feeling is I'm a little softer on that I don't believe that it's necessary for everyone to have an EMG. Even EMGs with regards to was a limb ever affected have not been proven to be 100%. So if somebody had their legs affected and we're doing their arms, and we don't find it, we can't say 100% that there was not evidence of old polio. We can make a statement that we believe that we don't see any affected groups and everything looks normal at this stage, and we can make the call on that. Otherwise, the only thing that we use the EMG and nerve conduction studies for, I mostly do it for the unaffected limbs, say in the upper extremities, to say, is there another process that's going on that might inhibit us from setting them on an upper extremity exercise program if their legs were affected. So if I do find a peripheral nerve problem, such as a neuropathy or a nerve entrapment, we can treat it aggressively quicker than waiting for it to be a problem and then waking it up by the exercise programs that we give for the upper extremities. So I find it more important for our patients that have relatively unaffected upper extremities that I want to rule out treatable cause first that might limit them from doing that upper extremity program, more so than saying that there was absolutely no evidence of old polio, because I think that that's a misnomer. I don't believe the research bears out that that's 100%. Our therapists wait for me, and they like to see that I write that I didn't see evidence of old polio in the extremities or in the upper extremities, so that they're able to do that exercise program. That's kind of their green light. But in my view, and looking at the research, and also our director of EMG from our program, I've spoken with her about that too, and she's kind of she's in agreement that the EMG has a questionable need with regards to treating post-polio patients. And I'd probably fall more towards that. So I don't think that it's imperative that everyone has an EMG and nerve conduction study. The majority of them have gone through it for their diagnosis of polio when they were younger. They had a bad experience with it. We try to make the process as benign as possible. If they choose to opt out, I don't believe that that's a detrimental thing, though I haven't had a patient refuse a study or stop a study by doing it, because I do limit the study to only answering those specific questions instead of checking 3 extremities and doing an extensive needle exam. I just don't find that that's necessary unless there is another problem that I was trying to rule out.
People who are responders, and that's an example of what I mean when I say I don't think we've really, teased out all of the underlying issues. I mean, post-polio syndrome is a bit of a wastebasket diagnosis. So people come in and they say, gee, I've been getting weaker over the last 3 years. I think when you really look closely, I think some people get weaker in a different way than others. And some it's kind of pretty progressive downhill, and others it's more like a stair step. Some kind of get weaker for a while, then they stabilize, and then they actually get stronger again. And that weakness might just be disuse. Sometimes you find out that they've changed the way they work. I mean, maybe they're doing more of a desk job, less walking around, long halls at the office, and, less exercise, you get a little weaker. So, it's just, I think there's just a lot we don't know, and probably never will. My feeling is very strongly that folks that have polio pain, I'm talking about the deep muscle pain and maybe the joint pain in weight-bearing joints, usually because the muscles supporting those joints have gotten weaker, that kind of pain is generally very treatable, but never with medication. So I'm an absolutist about that. If somebody comes in and says that their legs really hurt them when they, walk a long distance, and for some people a long distance would be a block, and for others it might be 5 blocks, or for some people it might just be around the house. But if there's a clear history that they've got muscle pain with weight bearing, with prolonged weight bearing,
stop bearing weight.
It's a no-brainer. It's a no-brainer. But you'd be surprised at the number of people who just struggle to find some way to stay on their feet. I mean, I understand where they're coming from, but on the other hand, if the pain is really, if it's bad enough, the old saying, pain is nature's way of telling you to slow down. And the same thing is true of weight-bearing joints. Or of your shoulders if, you're pushing a wheelchair or lifting heavy objects for whatever reason. That's just a no-brainer. The difficulty is getting patients to accept it. So, I think the worst thing you can do is give somebody strong pain medication to hide it, to cover it over, because you're not treating the problem, you're treating the symptom.